Okay, well, good afternoon and welcome to the Supporting Client Health and Wellness class presented by the Far Northern Regional Center Clinical Team. My name is Jen Badger. I'm an RN and I work for FNRC in the Reading office. And it's my pleasure to introduce some of the other members of our clinical team. First, I'll start with our staff psychologist, Dr. Bob Boyle.
Good afternoon, everyone.
And Bob's presenting today, so I'm glad that you're here, Bob. And last but not least, our RN in the Chico office, Nellie Camarena.
Hi, good afternoon, everyone. Welcome.
Hi, Nellie. It's really nice to have you all here today, and I hope that the information that we share is helpful to you. This is the fourth class and the fourth in a series of psychiatric presentations. If you happen to miss any of the other three, please go on to our YouTube channel and you can watch them there. You know, hopefully this is information that you're going to be able to use when you're supporting our clients. So without further ado, I'm going to pass it over to Dr. Boyle.
Thank you very much, Jen, and I'm glad to be here and share some information with you all this afternoon. As you recall, I had been on a few months ago and had talked about certain subsection of mental health disorders, and then Jen followed up by talking about medication that is used to treat those disorders. And we kind of flip-flopped it this time, which was actually based on my mistake. And Jen went first, and she talked about medications used to treat the diagnoses that I'll be sharing with you today. So hopefully you can recall what Jen shared, and you can always go back and relook at that presentation. But I'll be talking about the disorders that she was mentioning last time in terms of the medication that's used to treat those specific disorders. So, so I'm very happy to be here. And if you have questions as we're going along, you can unmute and ask a question. I'm fine with that. You can also put your questions in the chat. And I might ask Jen and Nellie's help to just maybe remind me that there's a question in the chat, and I'll try to address it that way. So this is part 2 of mental health diagnoses, symptoms, and treatment. If you could go to the next slide, please, Jen. So the first category of disorders that I'd like to talk about are what we refer to as anxiety disorders. And this one is a pretty easy category to understand because the word anxiety is really part of our common vernacular. And if we're human beings, we've all experienced anxiety to a lesser or a more severe degree. So when I say anxiety or anxiety disorders, I'm sure you can relate to that because we've all felt some level of anxiety about something or some things in the past, or maybe even in the present. So it's normal to experience some anxiety. That doesn't make it a diagnostic category. But really what makes an anxiety disorder is that is more severe. The anxiety is more severe, and it's more disruptive in the person's life. So we're not just talking about, you know, maybe you're taking a class and you get a little worried because you have an upcoming exam. You know, that's a very normal human experience, and that would not be classified as an anxiety disorder. The things that we'll be talking about that I have listed on the slide are usually much more severe and disruptive than that. So let's start off with specific phobias. So a phobia is anxiety that's attached to a specific thing, a specific situation. It's the person that has a phobia usually is well functioning in all other areas of their life, but that one area of what they're sort of singularly afraid of is pretty severe and would constitute what we call a phobia. And we're pretty familiar with the word phobia too, and you may be, and you probably heard of some of the more common phobias. And so I'm just gonna throw a phobia out there, and if you know what it is, unmute and yell it out, and we'll see how you do. Okay, there's one phobia called claustrophobia. What is claustrophobia?
Fear of enclosed spaces.
Yes, fear of enclosed spaces. So folks that are claustrophobic don't like experiences like being in an elevator with 10 other people. That's not comfortable and causes a significant amount of anxiety. So that's claustrophobia, one of the more common phobias. And some of us probably have some claustrophobia, at least to some degree. That's a pretty common thing. Does anybody know what acrophobia is? Acrophobia. This is actually one that I have. Not that you would know what I have, but.
Is it spiders?
No, but that's a good guess. Spiders is arachnophobia, which actually years ago was a kind of a horror movie that was made. So if you're deathly afraid of spiders, you may be an arachnophobe, but this is
Fear of heights?
Yes, fear of heights. So people that have acrophobia are really worried about, let's say, going up to the top of the Empire State Building. That would cause them a certain degree of anxiety to look out from the lookout up at the top. So that's acrophobia. Now there's a couple of, I just looked this up before doing this talk. There's one that I doubt that anybody will know, but I'll throw it out there. And if you get it, that's very impressive. But it's called coulrophobia, C-O-U-L, coulrophobia. Anybody know what that is? All right, let me give it to you. It's a fear of clowns, which probably isn't too disruptive in the person's life because you don't see a lot of clowns out there. But there are people that are really deathly afraid of clowns and get highly anxious in that kind of situation. This last one, I doubt you're going to know too, but I'll throw it out there and see if you know. It's arachibutyrophobia. Arachibutyrophobia. And I'd never heard about this one. And if anybody knows this, that's incredible. But what it is, which makes no sense to me at all, is a fear of peanut butter. So there's as many phobias as things you could imagine. I don't quite understand fear of peanut butter because I think it's delicious, and I'm sure some of you would agree with me there. But apparently that's a phobia that's been written about and that some people experience. So those are all specific phobias. It's being highly anxious, but the anxiety is connected to a certain thing, okay? So that's a specific phobia. Another kind of anxiety disorder is a social phobia, or now we call it social anxiety disorder. And social anxiety disorder is a kind of anxiety that a person feels in social situations. And usually what they feel is somehow they're going to be criticized or judged in that social situation. Now, actually, this kind of relates, when they question people about things they're most scared of. Does anybody know what the number one fear of most people is? And you can unmute and yell it out if you know it. Number
Public
one fear.
speaking.
Public speaking.
Public speaking, yeah.
Public speaking is number one, which is kind of a type of social phobia, because the people that are afraid of public speaking think, oh my gosh, I have to go up in front of other people. I'm nervous. They'll see how unprepared or unintelligent, you have a lot of fantasies about how it's going to go and what other people are going to think. But that's kind of a type of social phobia. But actually, fear of public speaking is a little more specific because you could probably go through maybe most of your life avoiding that kind of thing. But the person that is social phobic really gets highly anxious whenever they have to be out in front of other people, which, you know, being out with other people is a very common activity for us human beings. So that can be very paralyzing to have a social phobia or social anxiety disorder. And then the next two, panic disorder and generalized anxiety disorder, you may have heard of. Panic disorder is very acute and intense anxiety. So acute means that it comes on suddenly. And the good news is it also leaves suddenly. So it happens very quickly. It doesn't last a long period of time. A panic attack, you may have heard that, is part of panic disorder. A panic attack comes on sort of out of nowhere. So it's very acute. A person goes from 0 on a scale of 0 to 100 in terms of the anxiety. They go from 0 to 100 without a lot of space in between. So it's really acute and really intense, and it's typically very short-lived. And some of you may have experienced this. I think we've all probably experienced at least a minor panic attack in our lives about something or other. And it's really intense. It's kind of discombobulating. It's not a good feeling to experience that high degree of anxiety. And a person that experiences that sort of over and over again, we would call that person a person with panic disorder if they experience multiple panic attacks. So that's that acute and intense anxiety. Generalized anxiety disorder, in comparison, is something that is more chronic as opposed to acute. It's chronic, meaning the person with generalized anxiety disorder usually wakes up in the morning feeling anxious, goes through their day feeling anxious, and goes to bed feeling anxious. A person with panic disorder might go through a whole day without having a panic attack. And then once a month, they experience some acute, intense anxiety in the form of panic. So the generalized anxiety disorder diagnosis is one where it's really much more chronic and much more low grade. So the anxiety level isn't as intense, but it's just kind of always there and always at a low level. So that's another kind of anxiety disorder that we've identified. The next bullet point you'll see, which I think everybody has heard of this acronym and this diagnosis before, is PTSD, which stands for post-traumatic stress disorder. So in this situation, the person experiences a traumatic event, and what the traumatic event is can really vary between individuals. So it could be something like people that have been and experienced the campfire, the car fire, that's a traumatic event. If wildfire is a traumatic event, any sort of out of the ordinary weather event, like what happened in Florida a couple weeks ago. Traumatic events can also be interpersonal things, being molested, being raped, being abused. War, being involved in war can be traumatic. There's a lot of things that could be traumatic. So the person with PTSD usually wasn't experiencing anxiety before the traumatic event, but after they go through the traumatic event, they experience it afterwards. The event itself is usually anxiety provoking. And then afterwards, the person with PTSD tends to have nightmares, tends to relive the experience, has flashbacks. And it's a very difficult disorder to have. We first identified this actually after World War II veterans coming back and having difficulty adjusting, Vietnam veterans coming back and having difficulty adjusting to civilian life. And what we found that they were experiencing were a lot of flashbacks, a lot of nightmares about what happened, what they had been through. And so that's how this diagnosis first was noticed. And now, it's actually diagnosed pretty commonly because unfortunately, People can go through significant trauma in their life, but PTSD is an anxiety disorder. We used to have obsessive compulsive disorder in this list. We kind of moved that to its own category, but that used to be categorized as an anxiety disorder. So we have these specific phobias: social phobia or social anxiety disorder, panic disorder, generalized anxiety disorder, and PTSD. Now, in terms of how these are treated, I think Jen went through some of the medicines that are used to treat anxiety disorders in last month's training. There's anxiolytics, benzodiazepines. There are medicines that treat anxiety. And actually, they treat the symptoms fairly well, although, like with the benzodiazepines, a real downside side effect of that category of medicines is you can get hooked on them pretty easily. So you have to be careful when the physician is prescribing something like benzos, that the person doesn't develop an addiction to those medications. Another way that anxiety disorders are treated, and obviously I'm a psychologist, so this is sort of my bent. Not that I don't think medicines are useful, they certainly are, but usually with an anxiety disorder, you have to go at it probably both with medication and with something like psychotherapy or counseling. And there's certain forms of counseling that are very, very effective in terms of treating anxiety disorders. Okay, so I think there was a question in the chat.
There is.
Okay, Greg said, how can one know if they have a generalized anxiety disorder or a very busy, stressful life? That's a very good question. Because a busy, stressful life, by virtue of you using the word stress, means that there is anxiety in it. And that's true for all of us. Stress is part of life. Anxiety is part of life. I would say that the main difference and what makes a generalized anxiety disorder a clinical condition is how disruptive it is in your day-to-day functioning. So most of us that have a stressful life, we find good, healthy ways to cope with that stress, even if we still feel some stress. The person with generalized anxiety disorder is usually their adaptive functioning is very impacted by the anxiety. They haven't found good ways to handle it, and they might handle it in unhealthy ways, like overusing medication, any kind of addiction. So really, it's more a matter of degree and severity and how disruptive it is in your life. So I don't want you to think that because you have a stressful life, you have a diagnosis. That really isn't the case. But I mean, it could be. But most of us have anxiety, and we just try to find ways to deal with it. And there are good, effective ways to deal with it. So thanks for that question. Okay, Jen, if you can go to the next slide. Then we have a big category of disorders called neurodevelopmental disorders. And they're called neurodevelopmental disorders because they are present during the 0 to 18 years of age. That is considered to be the developmental period. And so these disorders all have their origins or genesis. They first get noticed and identified during the 0 to 18 years of age. And I listed a few here. And what I'll do is, list these, and then we'll go through them one by one. So we have intellectual disability, autism spectrum disorder. You're probably aware that those are two that the regional center deals with. ADHD, specific learning disorder, oppositional defiant disorder, and conduct disorder. So first, intellectual disability. Next slide, please. So there are three criteria for this disorder. One, the person has to have some kind of significant deficit in intellectual functioning. And we've, over the years, defined that as, at least in part, significantly low IQ scores, so significantly low scores on a standardized intelligence test. That's one of the primary ways that we can tell if there is a deficit in intellectual functioning. So when we're diagnosing something like ID, which we used to call MR, mental retardation, and intellectual disability is the newer term for this disorder, and a much more, I think, user-friendly term. One of the things we do is we depend on the administration of IQ tests and looking at those scores to see if a person has a deficit in their intellectual functioning. A second thing that has to be present is not only do they have to have a deficit in their intellectual functioning, but they have to have a deficit, significant deficit or deficits in their adaptive functioning. So adaptive functioning is just how the person does in day-to-day living with the day-to-day tasks that we have to face, like taking care of ourselves, like communicating, like taking care of our families, those kinds of things. So that's a second criteria for this disorder. And a third, like it is for all of these neurodevelopmental disorders, is the onset has to be before the age of 18. That's why sometimes when we have people that are referred to us at the regional center as adults, we really have to go back and look at documents and look at history to see how they were doing in terms of their intellectual functioning before the age of 18, because we have to establish that that onset was before the age of 18 in order to actually diagnose something like intellectual disability. So it's those three things: deficits in intellectual functioning, which is usually derived from IQ scores, deficits in adaptive functioning in terms of how the person is able to live their life successfully or not, and then onset at somewhere in that 0 to 18 range. And in terms of treatment for this, there really isn't any medication that treats intellectual disability. We don't have, the technology that has given us a pill or a liquid form that will gain IQ points or increase adaptive functioning. So we don't really have a medical treatment for this, but we do have other ways that we intervene. We intervene educationally by providing extra support, like in the school setting. We intervene by helping folks develop the skills that they do have. In terms of placement in a job setting, we can provide some job coaching and supervision so that they can be successful in a job kind of setting. And we can provide, I have the last bullet point of behavioral, CBT, and ABA. Those are all counseling kinds of interventions. Behavior therapy works very well with folks that have an intellectual disability. CBT stands for cognitive behavior therapy, and that works very well for people with ID. And ABA, which you're probably familiar with, and we actually are fortunate enough to have an ABA person on our staff now at Far Northern in Lisette Oliva, and she's an expert in using that intervention with our population. So all of those things in terms of counseling actually are ways to treat an intellectual disability. Okay, next slide, please. So the next disorder is autism spectrum disorder. And this is one that we used to have 3 separate diagnoses under the general heading of autism. We used to have what we called Asperger's disorder. We had full-blown autism, and then we had a third diagnosis in this category called pervasive developmental disorder not otherwise specified, which is quite a mouthful, or its acronym was PDD-NOS. So before the most recent diagnostic manual, which is the DSM-5, when then we had the DSM-4, we had those 3 separate diagnoses as all diagnoses of autism. And what we did, or not we, because I didn't have anything to do with it, but what the experts did when they revised the diagnostic manuals a number of years ago was they took a close look at autism in the close look at those 3 different diagnoses. And what they found was those 3 diagnoses had much more in common than they had that was different about them. And they also found that experts, like trained clinicians, it wasn't very reliable in terms of reliably diagnosing when it's Asperger's or when it's autism. So what was done was they decided to collapse those 3 diagnoses into one category. So instead of having 3 separate diagnoses for autism, now we just have one, which we call autism spectrum disorder. And so that was a pretty significant change, going from those 3 separate diagnoses to the one. So now when we talk about autism, we talk about autism spectrum disorder. And autism spectrum disorder is an individual who has difficulties in 2 general areas. The first bullet point is social/communication deficits. So some of the social/communication deficits we see and you see with our clients that have autism is poor eye contact, is difficulty communicating, maybe communicating more like a professor than a person sometimes, having very rote ways and rote things that they say over and over again, not using gestures. Those are all social communication deficits. And then a second area of difficulties are what we call the RRBs, or restrictive repetitive behaviors. People that have autism spectrum disorder sometimes will have, or often will have, a singular intense interest. So an interest in World War II trivia, or an interest in sprinkler systems, or an interest in dinosaurs. And they know everything there is to know about that, don't know a lot about other things, but really have put all their eggs in the basket of that one interest. Some of the repetitive behaviors you see with autism are things like hand flapping, toe walking, those kinds of things. So it's those 2 areas: social communication deficits, restrictive repetitive behaviors. And how we go about diagnosing this, which many of you may be aware of, but we have a best practice way of assessing, and that's by giving an instrument called the ADOS, which stands for the Autism Diagnostic Observation Schedule, and then going through the DSM-5 that has 7 different criteria that make up the diagnosis of autism spectrum disorder. So when we have somebody come through intake at the regional center, we usually refer them for a best practices evaluation, which includes giving the test called the ADOS and looking at the different diagnostic criteria to see if the person meets enough of those criteria to get a diagnosis of autism. And we've seen, certainly over the last 10 years, our referrals for this condition of autism spectrum disorder really increase. So most of the time when we're going to our eligibility review meeting every Thursday, we're looking at a lot of folks that have been referred to the regional center to see whether or not they may have an autism spectrum disorder. And in terms of treatment, again, there's no treatment, medical treatment for the condition per se. There's some ways that are used to treat some of the symptoms that people have. Sometimes people that have autism will engage in self-harming behaviors, or will get agitated very easily, and medicine may be given to help with those things, but it really isn't something that treats the condition itself. It just treats some of the manifestations of it. But some of the other things that really we found to be helpful, social skills training is really, really helpful, because since there's social communication deficits, people with an autism spectrum disorder can be educated about how to develop those social skills, and can learn how to relate better to others. Also, speech language therapy is used, and cognitive behavior therapy and ABA, just like with ID, are used pretty successfully to treat autism spectrum disorder. So as I said, intellectual disability, autism spectrum disorder, as you know, those are 2 of the the five different diagnoses that you would need to have to become eligible for the regional center. So we deal with both ID and ASD on a daily basis here, and you guys do as well in terms of serving our clients. Next slide, please.
I have a question about autism.
Sure.
So, and maybe you can clear this up for me. So I thought one of the reasons why they changed it to spectrum disorder is because they are now leveling the intensity or the disruption in someone's life, and they're up to level 3 right now. So you could have ASD level 1, level 2, or level 3.
Those levels are used to describe the severity of the symptoms.
Right.
But I'm trying to remember if we also talked about severity of symptoms when we talked about those other diagnoses. Maybe we didn't, but I don't think the severity of the symptoms and doing mild, moderate, or severe really had a lot to do with changing it from the 3 to the 1.
Okay.
But that you're right. That is, when we make people eligible, we try to identify how severe their symptoms are, because that is informative in terms of people that are gonna work with those folks. You can kind of get a sense from the assessment about how severe the symptoms are, by their scores on the ADOS and by how many of the DSM criteria they meet. And then it's just another way of kind of giving some qualifier about how seriously they're experiencing the symptoms of autism spectrum disorder.
Thank you.
You're welcome. So the next one is not a regional center condition, is ADHD. And ADHD stands for Attention Deficit Hyperactivity Disorder. So just so you're aware, we've kind of fooled around with the name over the years. So we used to have ADD, Attention Deficit Disorder, and then we would specify whether it was ADD with hyperactivity or ADD without hyperactivity. Now, which I think is even maybe more confusing in some ways, we have ADHD, Attention Deficit Hyperactivity Disorder. And then this first bullet point is the 3 subtypes you can have. So you can have ADHD predominantly inattentive type, ADHD predominantly hyperactive. I spelled that wrong, I apologize. I have hyperactive, impulsive, or ADHD combined type. So ADHD predominantly inattentive would be the kid or the adult who isn't, running around like they're activated by a motor, but just has trouble paying attention and staying attentive. And so this kind of kid is less noticeable in school settings because they're quiet lots of times. But still they have great difficulty focusing and concentrating and seeing things through. ADHD predominantly hyperactive impulsive type is pretty easy to see. I was just reviewing a report I had done on a kid that I had tested for the regional center. And I said in my report, the child assumed many different postures during the IQ test, like on her chair, under her chair, under the table, on top of the table, wandering around the room. That's predominantly hyperactive impulsive, which has to do more with what we see behaviorally with the person. ADHD combined type is a combination of inattentive symptoms and hyperactive impulsive symptoms. So they're the kind of kid or adult who has both inattentive and hyperactive impulsive. So those are the 3 subtypes that we have: ADHD predominantly inattentive, ADHD predominantly hyperactive impulsive, and ADHD combined type. This condition, and I know Jen talked about it last week with medication, is actually very successfully treated with medications. The issue has been that the category of medications that are used to treat ADHD are psychostimulants. And so, doctors are careful about prescribing this. And sometimes parents are reticent to have their child be taking a stimulant just knowing what a stimulant is, and that a stimulant can have some side effects like decreased appetite and decreased need for sleep and things like that, that are really uncomfortable and not good. I mean, we don't like to see kids on stimulants losing weight, and that does happen sometimes. In fact, back in the 60s, stimulants were prescribed for weight loss. They're not anymore, at least legally, but they were prescribed for the side effect that they have. But the history is that stimulants have successfully treated the symptoms of ADHD over the years, and the psychostimulants that have been developed are better and better with less side effects, not with no side effects. There's no medication with no side effects. But I've seen kids in particular, and adults too, undergo some pretty significant rapid change, positive change, when they get treated with Adderall, and actually with the psychostimulants, they have some that are long acting now, which is nice, because what used to happen in the old days, like when I was in graduate school and working in a school setting, is that kids with ADHD that were prescribed stimulants would actually have to bring some of their second dose of medicine to school, because they'd have to take it. It would wear off before school would end for the day, so they'd have to go to the nurse's office and get their second dose of Ritalin. Usually is what it was in the old days. Now we have some really good longer acting, extended release kinds of stimulants, where it doesn't wear off as quickly and can last even throughout the school day for kids. So psychostimulants are very commonly used. Also, psychotherapy in the form of cognitive behavior therapy or just plain old behavior therapy are both very effective in treating ADHD. Back when before I came to work for the regional center, and I was in private practice and working with kids and families, I had a lot of families that would come in. We'd maybe establish a diagnosis of ADHD for their child. They wouldn't want to try medicine right away, and I would always say, well, that's up to you. Let's try some counseling. If counseling doesn't work, that might be an indication we have to go with something else and add medication. And sometimes we did, not all the time, but sometimes we did. And medication, I've seen medication, as I said, be very helpful with this disorder. So that's ADHD. Okay, next slide, please. Specific learning disorder. And that is, sometimes people get intellectual disability and learning disorder mixed up. And because specific learning disorder, specific learning disability is a disorder that at the regional center, we're not allowed to, that's not a diagnosis for us. It's more of a diagnosis that gets identified in the school setting. And typically what it means is there's a discrepancy, a difference between the person's IQ and their achievement. IQ is thought to be what you have the capability of doing. Achievement is what you're doing in the real world. So oftentimes in school settings, what's done, school psychologists will give an IQ test and an achievement test, and then compare the scores. And if achievement scores are significantly lower than IQ scores, it means the child has higher ability, but their ability isn't getting accessed or worked out in the world, and they're having difficulty in different school subjects. Oftentimes, a specific learning disorder is in a particular area. I think you can have a reading disorder, a math disorder, a written expression disorder. And this is something that is usually not treated with medicine, but it's usually treated with more educational interventions. So, special ed teachers, resource specialist teachers are very expert in providing extra assistance and support for kids that have learning disorders. But again, a kid with a learning disorder usually has an IQ that is in the low average to high average range. It's just that their achievement scores and how they're doing in school is really lagging behind their potential or their capabilities. Next slide, please. And then we have two behavior disorders, ODD or Oppositional Defiant disorder, and conduct disorder. And of the two, conduct disorder is much more serious. So ODD, the kid that has ODD, and these are, again, that 0 to 18 neurodevelopmental disorders. So this is when it's diagnosed. So a child or adolescent with oppositional defiant disorder is characterized by a kid who's argumentative, defiant, angry, irritable, vindictive. In the old DSM, they used to say swears a lot, but they took that one out because, I don't know, I guess all people swear more nowadays. So it's not used as a specific diagnostic criteria for ODD anymore. Now you may look at that and say, oh, that, if you're a parent, oh, that describes every teenager I've ever known. But again, this argumentative, defiant, angry, irritable, vindictive, this is of clinical proportion. So it's the kind that really is disruptive in the kid's life, like he's getting in trouble at school, at home, he's losing relationships because of how argumentative he or she is. I say he just because there are more boys than girls that are diagnosed with both of these disorders. So it's sometimes referred to as a baby conduct disorder, in that it's just less severe. Conduct disorder is more serious. And that's when the kid is really going against the rights of others and going against societal norms. So this is the kind of kid that usually gets involved with the juvenile justice system, is a kid with conduct disorder because they break the law, they assault others, they steal, they rape, they assault, whatever, which certainly, assaulting another person is actually breaking their personal rights and actually societal norms both. So conduct disorder is more severe. And since it's more severe, it's more difficult to treat than ODD. ODD is pretty easily treated. Conduct disorder, it's a little more difficult. And in terms of treatment, in terms of medication, sometimes you'll see these kids on some low dose of things like Risperdal, or even an anxiolytic like for anxiety. But really, those medications are used to just kind of bring the agitation down. They don't really go to the core of what's going on. For that, I do think you need to really, the child or adolescent needs to get involved in some probably both individual and family therapy in order to deal with this type of problem. So if you were to, for instance, go to the Shasta County Juvenile Hall, or I think they call it Juvenile Rehabilitation Facility right now, I would guess, my guess would be about 75% of the kids that are there probably have a conduct disorder diagnosis. So that's ODD and conduct disorder. Next slide, please. Then there's neurocognitive disorders, which are things like dementia and delirium. And actually with dementia, we've divided it up now into either major or mild neurocognitive disorder. Major obviously is going to be more, it's impacting the person much more significantly than mild. And Alzheimer's, which you've probably all heard of, is one type of dementia. So there are other dementias too. Alzheimer's is actually the most common type of dementia and the one we hear of. And some of you, myself included, may have had close relatives or parents that suffered from something like Alzheimer's. And it's really difficult and sad for them and for family members too, because things like memory, decision-making, those are all very impacted by a diagnosis of dementia. And in terms of how we treat things like dementia, we do give medication, and there's some medications out there that don't really cure dementia or Alzheimer's, but it can, sometimes with Alzheimer's and other types of dementia too, people kind of decline cognitively and behaviorally, but the medications will sometimes help them have a longer period of plateau. So instead of just the decline being a straight line downward, it might kind of even out. They might plateau for a while and not get worse, which actually is a good thing. So the medication used doesn't really take the dementia away. it just kind of staves it off and causes the plateau to lengthen a little bit, which is a good thing. And, we provide, and people oftentimes require some assistance in their living situation from, assisted living situation all the way to skilled nursing facility.
French, please call extension 1681. Thank you.
Sorry about that. That's another way that this is treated. Next slide, please. And then this is a huge area, and I'm just going to go into it very briefly, which is the area of personality disorders. And you've probably heard of personality disorders, and we've identified a bunch of different types: paranoid personality disorders, schizoid, schizotypal, antisocial. You probably heard of antisocial is the one that we used to call the psychopath or the sociopath. That's now called antisocial personality disorder. That's the person that really has no sense of guilt, and usually are very highly manipulative of others. Borderline personality disorder is probably the least favorite personality disorder of therapists to treat, because borderlines are kind of up and down. They love you, they hate you, they cause a lot of chaos in any and all situations which they find themselves in. It's a very difficult personality disorder to deal with. And if you have one in a residential setting, it's a person with borderline personality disorder. It becomes very, very difficult in terms of their relationships with both staff and with other clients. So that's a very difficult one to treat. Narcissistic personality disorder, avoidant, dependent, obsessive, compulsive. We, really with these things, next slide, please. With these things, medication is used. It's usually used to control symptoms. It's one of those things, like a couple of the other disorders I mentioned, where medication isn't really treating the disorder itself. It's treating the manifestation. Sometimes people that have borderline personality disorder have pretty deep depressions. So they'll get treated with antidepressant medications. And so the antidepressant medication is treating the depression, but it's not treating their propensity to have unstable moods. That is sort of a different story. And we don't have a good medication to treat the unstable moods of a borderline personality disorder, but we do have antidepressants that can kind of take the edge off the bottom of the mood in terms of depression. Oftentimes too, with some of these more serious personality disorders, we find that they need intermittent hospitalizations, that they need, and this is at the psychiatric facilities, they need the safety and structure of the hospital to kind of reconstitute. And so particularly with something like borderline personality disorder, those folks are typically intermittently hospitalized, sometimes throughout the entirety of their life. And psychotherapy is very useful, although difficult and long-term in terms of treating people with personality disorders, but it is very effective, and it is a form of treatment that should be attempted. Although, like I said, most therapists don't really enjoy treating personality disorders because there's just so much interpersonal chaos in doing so. But psychotherapy is a proven form of treatment, although, like I said, it's usually long-term. It's not the kind of thing you can go in 4 or 5 sessions and get a lot better. It's usually years long. So so the personality disorders are probably a talk in and of themselves, but I just wanted to mention those and mention that medications used to treat some manifestations, but not really the disorders themselves. All right, next slide, please. And I guess that was the last slide. So I know I went through this really quickly and then give you a sort of broad brushstroke about these different diagnoses, but any questions or comments? I didn't even look to see if there's anything more in the chat. Doesn't look like it.
How much does nurture influence these disorders and different things that we talked about as far as expression?
Oh, that is such a good and broad question, Greg. You know, my general rule of thumb in understanding any psychopathology is that it's probably a combination of nature and nurture. So it's probably a combination of genetics, which really there's nothing we can do about that. You know, our parents are our parents and their parents were their parents, and things get carried down genetically from generation to generation. And it's true with medical conditions like, you know, heart disease is something that's genetically passed forward from generation to generation. So is depression. So is schizophrenia. So, but just because you have a family history of it doesn't mean that you'll necessarily have the disorder itself. It just means you have a better chance, higher chance of developing that kind of problem. So nature is always a part of it. And when we look at something like intellectual disability, nature has a significant part of that in terms of the IQ that you inherit from your parents is a significant variable. So nature is a significant variable. Nurture is also a significant variable in most psychological conditions. So the any problems in nurture, like problems with the environment, like being traumatized, like being neglected, like having a borderline mother, usually goes a long way to creating, when we talk about borderline personality disorder or borderline personality sort of child, adolescent, and then adult. So both of those factors are really important and both contribute. And lots of times it's hard to tell how much is one thing and how much is the other. And we just know that both contribute. So I don't know if I hope that's not a cop-out answer, but it's just really, really difficult to tell. And it's really more case-by-case kind of situation with all of those things.
That was a fantastic answer. I appreciate it.
Okay. Other questions, comments?
Sorry, Dr. Boyle, one more question. The one where it was like the underachiever, where the IQ was there, but it didn't match up. If that's identified as an adult, is there still hope for progression, or is that something where it's kind of like there's a window that you can miss?
No, I think that can be addressed as an adult. The only problem is that since the school setting is usually where it's identified, and hopefully it's identified early. And one of the reasons, we have special education is to provide specialized services for folks that have things like learning disorders or speech disorders or any kind. There's a lot of different special ed categories. So if you're an adult and you find that be happening, you may not be in a setting like a school setting where the resources will be right there. But that being said, if that's something that's identified as an adult, there are things you can do to, I think working with an educational specialist, even as an adult, or a therapist, if that's part of the picture too, psychotherapist, that can be helpful. So it's not that nothing can be done. It's just that you're not smack dab in the middle of an environment like in the school setting that has those kinds of resources. So, but there are educational specialists out there that work with adults that have learning disorders and learning disabilities, certainly.
I have a question.
Yes.
Does the regional center work with personality disorders? No.
Well, we do have people that are regional center clients that have personality disorders, but having a personality disorder does not qualify one to be a regional center client. So the regional center conditions are intellectual disability, autism spectrum disorders, cerebral palsy, uncontrolled seizures, or what we call fifth category, which is a person that has a condition similar to an intellectual disability, like maybe their IQ is just a little bit higher than the cutoff IQ for intellectual disability, or a person that requires similar services. So those, you have to have the diagnosis first, and then adaptive deficits connected to it to be a regional center client. So having a personality disorder does not qualify one for regional center services. But we do have clients that qualify under those other categories that also have personality disorders. So if you work in a residential setting, you may find yourself dealing with someone who has both autism and a personality disorder, or ID and a personality disorder. So yes, we have clients that have that as an ancillary problem, but it's not the thing that's made them eligible as a regional center client.
Thank you. Do you think enough awareness is that there is enough awareness for all of these interrelated factors for care providers or other people that might work with clients?
There is absolutely not enough awareness. And that quite frankly is the reason that we're bringing these topics forward to you all, is because I don't think there is enough. I don't think you've received enough information out there about these things, and we want you to have that information because our clients have those kinds of problems. So, the more we can talk about it, the more I can share information, like with psychological disorders. I think the better off you'll be, the better trained you'll be to see those things and to deal with those things. So yeah, no, I think with mental health in general, there's not enough information out there. Interestingly, I think in the last 10 years, the awareness has increased. Even I think of like the last Olympics with Simone Biles, who was, struggling internally because of some, I think, trauma that she had that affected her performance. It was really out there as front and center mental health concerns. And so I not that I feel bad for Simone Biles, but I do think that when people come out and share their story about their mental health issues and struggles, it really helps, because we can say, oh gosh, it's out there, and it's out there with everybody. And so I think the more awareness we can have, all of us, of these kinds of conditions and problems, the better off we're going to be, and the better able we're going to be to serve our clients.
Thank you.
Yes. Okay. Any other questions? I know it's 3:01.
There's no more in the chat box.
Okay.
All right, but if any questions come to mind later and you want to ask Dr. Boyle, he can be reached at the Regional Center anytime, as well as Nellie and I. We're more than happy to provide you with any information that you're looking for.
Yes, absolutely. Please reach out.
Great. Well, thank you, Dr. Boyle. It was a wonderful presentation, as always. Really appreciate you.
You're welcome. Take care, everybody.
Thank you.
Thank you, Dr. Boyle. Thank you,
You're welcome.
Jan. Thank you, Nellie.
Thank you.